Hello once again. We've come to the last subsection of our presentation, Axial Skeleton and Development. We'll be talking about ribs in sternum in this presentation. So, what topics will we be covering? We'll be talking about the development and structure of ribs in sternum. We'll talk about the rib defects and the sternal defects. So first of all, ribs. The bony portion of each rib is derived from the sclerotome cell. It grows out from the costal process of the thoracic vertebrae. Costal cartilages are formed by the sclerotomal cells that migrate across the lateral somatic frontier into the lateral plate mesoderm. So, each rib has two parts. This is the bony portion. This is the cartilaginous portion. The bony portion originates from the sclerotome cell. The costal portion originates from the sclerotome cell that migrates across the lateral somatic frontier into the lateral plate mesoderm. The bony portion grows out from the costal process of the thoracic vertebra. Now, let's talk about sternum. Sternum develops independently in the parietal layer of lateral plate mesoderm in the ventral body wall. So, ventral body wall, you must remember the dorsal and ventral orientation of the embryo. The sternum develops within the ventral body wall. It is developing independently and it develops within the parietal layer of lateral plate mesoderm. There are two sternal bands which are formed on either side of the midline, which are then supposed to join together to form a single sternum. These later fuse to form cartilaginous manubrium. Manubrium is the upper part. Sternebrae is the two portions of the sternum that meet together in the midline, and the xiphoid process. This is the xiphoid process. So, what are the rib defects? The most important rib defect is cervical rib. It occurs in about 1% of the population as a whole. It usually attached to seventh cervical rib. Cervical rib is usually attached to the seventh cervical vertebrae. Though the form of attachment may be different, it can also be attached to first thoracic rib as well. It may impinge on brachial plexus or the subclavian artery. Obviously, the location compacts the thoracic inlet. The thoracic inlet is already a very tight space, and very important neurovascular structures, including the subclavian artery as well as the brachial plexus, lie there. So it can have an impinging effect on that, which can cause varying degree of anesthesia in the limb. The person may have atrophy. It is a very detailed discussion which will be taken up in subsequent lectures. So let's talk about the sternal defects now. So we can have a cleft sternum. It may be complete or located on either side. The thoracic organs are covered only by skin and soft tissue. So if there's a cleft in the sternum, the thoracic organs that lie behind the sternum will be exposed and will be covered only by skin and soft tissue. The sternal bands fail to grow together in the midline. The cause of this cleft in the sternum is obviously the sternal bands, which were supposed to fuse with one another in the midline, now fail to fuse. So, hypoplastic ossification centers and premature fusion of sternal segments may occur. Hypoplastic ossification centers may form, and there may be premature fusion of the sternal segment, so that a mature sternum has not yet been formed, as a result of which some areas of the organs might not be covered and protected by sternum as they were supposed to be. In infants with congenital heart disease, this may occur. Two important sternal defects are pectus excavatum and pectus craniatum. The pectus excavatum is depressed sternum. This is sternum. If it is depressed posteriorly, so it forms pectus excavatum. Pectus craniatum is the anterior projecting, if the sternum is projecting anteriorly with bilateral flattening of the chest, this is known as pectus craniatum. The cause of both these is either abnormal ventral body wall closure, ventral body wall not being closed properly. It can also cause sternal defects, thoracic defects, abdominal defects, and even urogenital defect, or abnormal formation of costal cartilages in sternum. So this can be the reason of it. So this was the last subsection of our development of axial skeleton presentation. In this subsection, we talked about ribs, vertebrae, vertebral column, ribs, sternum, and their clinical correlates. The most important clinical correlate in this was pectus excavatum and pectus craniatum. You may commonly see these patients, though these patients might not have physiological abnormalities. However, it might appear visually unappeasing to the patient, and the patient might want corrective surgery. In that case, you must advise the patient as to what is best medically for the patient. Never go for a surgery that is not required. Never go for a procedure that is not required and only enhances the physical appearance of a person. So if the patient still wants it, there is no bad press in doing that surgery. However, you must always recommend that only a medically appropriate procedure should be undertaken, so that the quality of life must be improved for a patient. With that is all for this presentation. Keep watching sqadia.com. Till next time, bye-bye.